So students, in continuation we will cover the last topic in anal canal, that is anal intraepithelial neoplasia and anal cancer. Okay. So what is anal intraepithelial neoplasia? Previously it was called squamous cell carcinoma in situ or Bowen's disease and names like that. These are not used now. Basically, you have dysplastic epithelium involving lower one-third. We call it AIN grade 1. When you have dysplastic epithelium involving two-thirds of the epidermal thickness, we call it AIN 2. And similarly, full thickness is dysplastic epithelium, we call it AIN 3. That is anal intraepithelial grade 1, 2 and 3. You can also call it 1 as a low grade, 2 as a medium grade and 3 as severe grade anal intraepithelial dysplasia. These are precursors to anal carcinoma. Okay. So what are the predisposing factors for anal intraepithelial neoplasia? Basically it's the human papillomavirus. Human papillomavirus, as you know, there's hundreds of them are there, but especially type 16, 18, they are known to cause dysplasia and malignancy. Okay. Also those who are immunosuppressed because of some medications as in organ transplantation, or those with HIV, homosexual males, they are more prone to develop this anal intraepithelial neoplasia type 2, 3 and then anal cancer. Okay, so how do we recognize that there is anal intraepithelial neoplasia? Basically what you do is we stain the anal canal or swab it with acetic acid, about 5% acetic acid. This acetic acid is taken up by the dysplastic epithelium and it will appear as white, starchy white appearance will be there. So you know that this white tissue is dysplastic and you can take biopsy and examine it in the microscope. Okay. Another staining we do with the Lugol iodine. The thing is, Lugol iodine is taken up by the normal cells, not by dysplastic cells. Okay, so the normal cells will have a woody appearance, whereas the dysplastic epithelium will be normal yellow looking. Okay, so this is how you stain it, and you can take a biopsy and then confirm it. Okay, so how do we treat this anal intraepithelial neoplasia? One thing is excision biopsy. Other thing could be application of topical creams like 5-fluoro uracil cream you can apply, or imiquimod you can apply, which may help. If it is very early grade 1, patient can be kept in follow-up for every 4 to 6 months. The patient is examined. Okay. Now coming to anal carcinoma. Anal carcinoma, you see, below dentate line, you know the squamous epithelium is there. So the commonest cancer here is squamous cell cancer. Squamous cell cancer. Okay. Other cancer can be above the dentate line. It can be adenocarcinoma. Adenocarcinoma can arise from the epithelium above the dentate line, or can arise from anal glands, and adenocarcinoma can also arise from fistula in anal. So there are 3 places where it can arise. Okay. Now, squamous cell carcinoma is the commonest carcinoma, and as I said, the predisposing factors are human papillomavirus type 16, 18, HIV, homosexual males, and immunosuppressed persons. Those with organ transplantation, they are more prone to get squamous cell carcinoma. How will the patient present to you? They usually present with bleeding per rectum or mass, mucus discharge, pain. If the malignancy involves the sphincter, patient will become incontinent. The incontinence can occur. So this is how they present to you. And And for confirmation, of course, you will have to do a biopsy. Small incisional biopsy can be done. Or you can do a colonoscopy to look the whole colon if there is anything else is there. And for a staging of, as we do in any other cancer, you have to do a staging. We will do by a CT chest, CT abdomen, CT pelvis. Okay. MRI can also be done of anal canal to see if the malignancy is involving a sphincter or not. Okay. Then how do we treat these anal cancer, squamous cell cancer? See, squamous cell cancer is basically treated these days with a regime we call Nigro regime, Nigro, Nigro regime. Here it is combined chemotherapy plus radiation therapy to the lesion. Usually chemotherapy applied is 5-fluorouracil plus mitomycin or cisplatinum sometimes. This is given, and then radiotherapy is also given. Majority of these tumors, they will disappear or regress significantly with chemoradiation. If after chemoradiation a small thing persists, you take another biopsy, a persistent disease, then you can go for abdominoperineal resection. Whereas the anal canal together with the sphincter, rectum, mesentery and nodes all is removed, and an permanent end sigmoid colostomy is made. Okay, so basically treatment is chemoradiation, and if it recurs or relapses, then abdominoperineal resection can be done. Very small tumor not involving a sphincter, limited to mucosa, submucosa, you can do primary local excision as well. And as adenocarcinoma, as I said, adenocarcinoma arises from near the dentate line. It is very similar to the adenocarcinoma of rectum, except that it usually involves inguinal nodes and femoral nodes early. It can arise from anal gland, it can arise from the anal fistula, and the treatment basically is same to the adenocarcinoma in colon, that is abdominoperineal resection and end sigmoid colostomy. Sometimes malignant melanoma can occur in anal canal as well. There are melanocytes present in the squamous epithelium below the dentate line, and which can turn into malignant, and they usually mimic the thrombosed or strangulated external hemorrhoid. Okay, so here also there is anal malignant melanoma is very serious and very poor prognosis lesion. It usually spreads very fast and patient dies with distant metastasis. So aggressive treatment like abdominoperineal resection is not recommended. Basically local excision should be done in these cases. Rarely abdominoperineal resection might be needed. Okay, so this is all about anal cancer. Next time we will discuss about rectum. Thank you.